Hi guys, I am Savannah Goodlet and I'm here to talk to you today about intussusception. So, intussusception is a sudden onset emergent medical condition where the bowel telescopes itself and becomes obstructed. This typically occurs in older infants and younger toddlers. However, it can occur at any age. The most common site is the ileococcal sphincter, so where the large intestine and the small intestine meet. Um, and However, it can occur at any point in the intestinal tract. The majority of intussusceptions are idiopathic. However, they do most frequently occur in the fall and winter, so during the viral seasons. It's seen in about 1 in every 1,200 children. Some predisposing factors to intussusception are a history of polyps or diverticulum, anorexia, or unregulated anticoagulation therapy. So the anorexia causes your bowel muscles to become pretty flaccid, resulting in the ability for it to relax and then just enables that telescoping mechanism. And then the anticoagulation therapy issue is it can cause the submucosal hemorrhages, causing some irritation, and it's essentially the same concept as with the viruses the week before for those patients. Basically anything that can irritate the bowel lining and the intestinal tract long enough for it to swell, and then as the swelling's coming down, typically that telescoping motion happens, causing the intussusception. So the three questions you want to ask is, what symptoms do you have and when did they begin? Is the pain intermittent or consistent? Is your stool different than usual? And then just to throw in there, have you noticed a swelling or lump in your abdomen? So the primary symptom of intussusception would be that it is this intense abdominal cramping for anywhere from 5 to 20 minutes, and then it relaxes. And then there's another phase of 5 to 20 minutes of just this intense abdominal cramping, and then it relaxes. Especially if this is in kids, it's kind of hard to diagnose and differentiate because they may have nausea and vomiting, they may have the jelly blood in their stool, may have fatigue and lethargy, may have decreased PO intake, or they could literally be running around the room playing and then just have an attack and it hurts for 15, 20 minutes and then they're fine. I will say most patients that I've seen and most patients in the literature, decreased PO intake is very, very common. So the pain being intermittent, it's acute onset, severe abdominal cramping, comes and goes. Stool would have the rectal bleeding. And then, have you noticed any swelling or a lump in your abdomen? So the lump in your abdomen in your upper right quadrant, or in the patient's upper right quadrant, there may or may not be a mass. Typically a sausage-like mass is how to describe it. And then so just below that in the right lower quadrant, there should be like an absence of bowel, and that is pretty definitive of intussusception. Keep in mind when we are assessing pediatric patients, assessing a screaming child it's not, the physical exam is going to be pretty unremarkable for the most part, just because it's so difficult to assess sick babies. So the three primary treatments: an air enema, barium enema, or surgical repair. So air and barium enemas, typically once these have been administered, the patient may be observed in the ER, or they may need to be admitted for 24 hours or so just for monitoring, but you can expect a full recovery. Surgical repair, again, expect a full recovery for the most part if it was caught early enough. So if the patient presents with signs of peritonitis, distended abdomen, And this has been, they've had intussusception for a while that's been undiagnosed. We are looking at necrosis of the bowel at that point, and they're potentially going to need a more invasive surgery, and they could or could not have a colostomy at that point. So there is the 3 priority teaching components. There is a small, about a 5% chance of reoccurrence. So you would want to teach them to monitor closely for the signs that they saw before. So pain, signs of lethargy, blood and stool, abdominal distension. Once they go home, they can have a regular diet. We want them to eat. We don't want them to miss meals or to, have bowel rest, because anorexia can be a predisposing factor to this. And we also want them to return to normal activity and go on about life as tolerated. Thank you guys so much. I hope this was helpful.